Thank you so much. I'm honored to be able to follow Melissa's very touching video and comments, and grateful to the PAN Foundation for the opportunity to present this case study. I know everyone in this room knows this, that U.S. healthcare costs are rising, but I just love to, any chance I get to share this really cool infographic from the 2011 IOM report, which really puts into perspective how much healthcare costs have risen over time relative to most consumer goods. We've seen also over the last decade an increase in premiums and out-of-pocket costs for employer-based health plans, and a rise in the proportion of health plans with multi-tiered formularies in which specialty drugs fall into the highest cost-sharing category. And this is particularly relevant in oncology, where we've seen a rise in the number of oral chemotherapeutics. This table shows the oral chemotherapies that have been approved over the last 5 years or so, and you can see for many of them, monthly costs are in excess of $10,000. Many investigators in the oncology world have really begun to explore the impact of the rising cost of healthcare, in particular in oncology, on patients. And we've seen some studies showing that a substantial portion of patients with cancer experienced financial hardship. This is data from the 2011 Medical Expenditures Panel Survey, that close to 20% of patients experience financial hardship, material financial hardship, or psychological financial hardship, which is characterized by anxiety and stress around paying for cancer care. Patients with cancer also experience changes in employment in terms of missed work days, number of days spent in bed, and in general, disability related to their diagnoses. And a study from our group, we looked at rates of bankruptcy in patients with cancer in Washington State relative to individuals without cancer, and found a substantially higher rate of bankruptcy filings in individuals with cancer. So many of these studies have really made us aware of this problem of financial toxicity in the cancer world, which is really a constellation of symptoms: bankruptcy, debt, anxiety, loss of work, and difficulty meeting basic expenses. And we've started to see some reports suggest that financial toxicity can lead to impacts in outcomes: treatment adherence, poorer quality of life, lower clinical trial participation, and perhaps even worse, survival. So in terms of thinking about next steps, I think we're at the point where we need to think about real-time strategies to address the problem of financial toxicity in cancer. I've sort of outlined this pathway between cancer diagnosis and financial hardship. There are factors around the high price of cancer drugs, cost sharing, and insurance plan design that might influence this pathway, but also factors at the patient level and clinic level that influence this pathway: lack of cost transparency, lack of communication about costs, lack of financial literacy resources, and lack of consistent access to patient assistance programs, even though these programs are out there. And so really we wanted to design an intervention around the patient and clinical factors that lead to financial hardship in cancer patients. And so our goal was to design a financial literacy and navigation program, first by talking to patients about what they wanted in such a program, developing the program and testing it, and moving towards a larger study investigating the impact of such a program on patient outcomes. So the first step, and really the focus of this case study, was talking to patients about their financial experiences during treatment, what their perspectives were on communicating about costs, and their interest level in a financial literacy course. We talked to patients about their experiences before and after cancer diagnosis, and in particular we saw that a substantial proportion of patients who were employed before diagnosis ended up becoming unemployed, filing for disability, or taking early retirement. We also saw a significant decline in income before and after diagnosis. A substantial portion of patients experienced issues such as debt, non-adherence, using savings, retirement, and so on to pay for cancer care. Interestingly, patients did not routinely discuss costs with their providers, or seek outside advice about finances, and very few patients had actually prior knowledge about treatment costs. This is something that Melissa mentioned in her presentation. And only half of patients thought that physicians should actually discuss costs of treatment when prescribing, making treatment recommendations. And there were some really interesting statements from patients that we interviewed during the context of this study, and I'll just read some of them. Since there is no money and no way to afford the chemotherapy, it is too overwhelming to discuss costs. My well-being takes precedence, so whatever sacrifices would have to be made would be made for health care. When your financial status is not good, it is paralyzing to know the cost in advance. And some concepts around discussing costs potentially being a way of steering patients away from optimal care. And so we really thought that part of any program we developed would really address some of these concerns and barriers to discussing costs with providers. Ultimately, we found that the majority of this group of patients wanted a financial literacy and counseling program. Most of the majority of patients thought that this program should be administered in person and should start at diagnosis and continue periodically throughout treatment. These were the topics of greatest interest to patients: money management, where to look for co-payment assistance, and how to choose and navigate an insurance plan. So we decided to create a financial literacy course addressing some of these topics, as well as a way of providing patients financial assistance through partnering with organizations that provide some of these supports. And really, we struggled around providing transparency around costs, mainly because it's difficult to actually provide cost estimates in real time. So our program really was a partnership between Fred Hutch and the Seattle Cancer Care, which is the clinical arm of the Fred Hutch, and then a local Seattle-based organization called SENSE, which is a financial literacy and organization that really specializes in providing education and money management, budget planning, retirement planning, bankruptcy counseling, and so on. And then Patient Advocate Foundation, which many of you in the room may be familiar with, which is a national organization that deals with provides various navigation services, including co-payment assistance, dealing with insurance appeals, disability applications, and so on. Our goal in the pilot study was to recruit patients within 1 year of a non-metastatic cancer diagnosis. We started with a 3-month window, and that proved to be too difficult to engage patients that early in their diagnosis. Patients who received or will receive some form of treatment, and patients who were able to read and speak English. Eligible patients were consented. They received a group financial literacy class at the Fred Hutch. Then they met with financial coaches from SENSE and were contacted by Patient Advocate Foundation, and this contact occurred once a month for 6 months. Halfway through the program, we decided that the live courses were really not feasible. It was hard for patients to get there, and so we switched our approach to allowing patients to watch a video with the financial literacy information at home online. We did try and provide information to patients about their own insurance benefits, including their deductibles, out-of-pocket limits, and co-payments and co-insurance for typical services, which, interestingly, most patients didn't have this information readily available, and I know I certainly don't know all of these details of my own insurance plan. So patients did find this information helpful. We consented 34 patients to this program, 18 to the live class portion and 16 to the video class. We did have a substantial amount of dropout for various reasons. The most common was that people were very overwhelmed with treatment and the logistics around that. In total, we had 20 patients complete some component of the program. So the majority did engage with our program. This is a busy slide, I know, but the participants and those who withdrew from the program were similar in terms of these characteristics I list here. All patients in our cohort were insured. 25% of patients had Medicaid. The rest had commercial or Medicare insurance. A substantial proportion of patients experienced debt during treatment, declines in income, some loans from family and friends, and denials for coverage during the course of treatment. A substantial portion of patients, close to 40%, reported high financial burden, and close to 50% reported high anxiety about treatment costs. During the course of this program, there was high satisfaction with all components of our program, and we're looking right now at some of the costs recuperated for patients during the context of this program. The most common interventions made on behalf of patients by Sense were help with budget planning, retirement planning, and questions around medical bills, and by Patient Advocate Foundation, co-payment assistance, help with cost of living issues, and help with disability applications and employment rights. So moving forward, our goal is to take what we've learned in our pilot study and really move towards doing a randomized study to hopefully prove that helping patients through this process of dealing with the cost of care might actually not only decrease financial hardship, but improve their clinical outcomes and maybe have the added benefit of improving revenue to the treating institutions. So our goal is to design an intervention allowing organizations that we partner with to do what they do best. We're going to continue working with Sense and PAF on this study, and also including an organization called Family Reach, which has historically been involved with providing grants to families with children of cancer, but also expanding to working with adults with cancer, and this organization provides small grants for household expenses. Our goal is to enroll patients with early stage breast and colon cancer, to a proactive intervention where patients are contacted routinely by these organizations, or a reactive program where patients are given this information on how to contact these organizations but not actually proactively navigated. And we'll be looking at various endpoints, including financial hardship, quality of life, outcome, and costs recovered by institutions. And with that, I'd like to just acknowledge my collaborators on this work, and I thank you for your attention.